stand here with Dr. Bill Smiddy. Dr. Bill Smiddy completed his medical school at Johns Hopkins University and went on to complete both his ophthalmology residency and retina fellowship at Wilmer Institute, Johns Hopkins. He is internationally recognized as a leading retina specialist and is professor of ophthalmology at Bascom Palmer Eye Institute at the University of Miami since 1989, where he has been named the M. Bren Green Chair in Ophthalmology. Dr. Smiddy has been described as a retinal legend. He is an editor, reviewer, and one of the most extensively published retinal surgeons. I thought I would look him up on PubMed last night, and I saw a listing of 20, and I thought, 20? That doesn't sound right. And I saw, oh, it's 20 pages. He has 198 publications associated with his name. His research interests include macular surgery, retinal complications of anterior segment surgery, diabetic retinopathy, cost-effectiveness of retinal treatments. On a personal note, I met Bill years ago when I was a cornea fellow at Bascom Palmer, and I've known him to be humble, honorable, and well-respected as a retinal surgeon and mentor, inspiring students and pursuing excellence. So thank you so much for being here this morning. Welcome, and look forward to hearing from you.
Thank you, Jill, and thank you for the opportunity to come to the meeting today. It's always a pleasure to come back here and a blessing. I see some faces that I've recognized, but it's good to see that there's a lot of new faces because it speaks to the regeneration of this society. So today I'm hoping to kind of appeal to you with a topic that's a horse of a different color for most of us. Utility. You know, we all want to be useful, don't we? We all want to feel, excuse me, whether it's in our practices or in our life that we're contributing. In the complexities of life, it's very easy to lose sight of that and to get wound up in the moment and in the immediacy. So the topic I'm going to try to go to today is this thing called cost utility. And the idea is to value, to assign a value to what we do and to maybe be able to compare that to the value of other fields of medicine in a way that we can appeal to our tuition, but maybe put some numbers, dress up what we think to be what's valuable and not valuable, in a comparative way. There's clearly some controversies with regards to methodology, the ethics of it, the application of it, but I'm going to just try to introduce you. Now, for some reason, the builds aren't working right. Somehow it's come up all immediately with all the builds, but anyway, hopefully that's not going to be a problem going forward. But underlying that is a picture of my first year residency class in 1984, and I was indicating that Ronald Reagan, you see his top there, was president. And a lot has changed, though, in those 35 or so years. The public, the debt has gone up at least tenfold. Healthcare spending has gone up about tenfold. Oh. And now this isn't advancing for some reason. Okay. Did that skip over? Okay, good. Now, I won't go through the details here, but I want to just a brief history of health insurance is that in fairness to the increase in costs, some 90% of things that we do today were not present as therapeutic options in 1950. And that may explain why there's been this explosion in our expenditures in healthcare, individually and corporately. And again, the builds aren't working, so I'm going to just have to explain some of the things that get obscured here. But one of the things that is alarming to me as a practitioner, and has been for some while, is that a lot of attention is applied to all these Medicare cuts and healthcare cuts. But in fact, what's really happening is that the costs of the drugs and the therapeutics are what's really skyrocketing, whereas the costs of the professional fees actually are decreasing in real terms. So it doesn't really make a lot of mathematical sense to be cutting what's already been cut when what's not getting cut is increasing. I'm not advocating, but how can we defend or apportion these practice patterns? Well, I want us not to take the appearance of the après nous le déluge of Louis XVI as the in the heels of the French Revolution. It was interesting to me as well that even Karl Marx later sort of adjusted this statement after him, the deluge. I mean, we're enjoying really a period of time of somewhat unfettered, believe it or not, payments right now. But there's a limit to what we're going to be able to do. And some of these expensive treatments, I think we need to understand. We need to reel in and be good stewards of them, because things that are cost effective is what we should reserve our expensive treatments for. And maybe this cost utility analyses is something that we can hopefully do better for. And this is not a topic that we can just forget about and let somebody else worry about, or else we're going to find that the healthcare executives, the legislators in Washington are going to make these decisions for us. So to try to launch in, I just want to give you a high-level general understanding of what some of these things entail. There's just a few terminologies. Cost comparison is how do we do the same thing similar with different costs. Cost minimization, how can we do things with lower costs. Cost benefits really not as much in a medical term as much as it's in a corporate term. How can we get more benefit, typically in dollars, out of an investment of dollars? Cost utility is the closest to that, and that's how we can evaluate the cost or utility and therefore create these things called the quality adjusted life years, the value of some of these things that we're doing. Just a couple brief examples. A cost comparison might be comparing one health plan to another, one car maker to another. Cost minimization might be, well, how can we get around from point A to point B for a lower price? How can we accomplish the same thing with, for example, Lucentis or aflibercept versus bevacizumab? Cost benefit, is there something we can do? Again, this is more utilitarian than medical, but occupational therapy, should we invest in that versus just allowing long-term care to take over? But cost utility is something that I've alluded to, but it kind of is an amalgamation of many of these same principles. And unfortunately, again, with these builds, where should we appeal? Well, we should appeal to the most authoritative and standing text and see whether or not we get any answers there, right? So the only, as far as we know, physician who penned any of Scripture was Luke. And in the context of the dishonest manager, he says here in Luke 16:2, he called upon and said, "How is it that I hear of thee? Give an account of thy stewardship, for thou may no longer be a steward." On the other hand, the Good Shepherd, just the chapter before, he describes how a lot of effort will be paid for that one lost sheep, and understand, or that lost coin, and indicating that we can't just look coldly at the dollars in this whole thing. Now, clearly, these writings in Luke are pertaining to looking for salvation and lost souls, but it makes an interesting comparison, I think. The bottom line is God's not really explicit to us, so we kind of have to let our conscience, to some degree, be our guide. How do we measure utility? Well, it's really a combination, a product of both time and quality to get a utility value. There's a number of quality of life measures that you've probably heard of, this thing called the VFQ-25 and a bunch of other just sort of questionnaires that are attempting to ask the patient whether they can do certain useful everyday tasks or not. Those have a lot of difficulty with really being verified from one setting to another. What's really gained the most traction in this field is what's called the time trade-off method. And that is where you ask a patient with a given condition, how much of your remaining life would you give away in order to have 100% of your health for a given health condition? So there's a utility value of 1 for complete health, a utility value of 0 for no health, and for death. And we'll give you some examples of that. The beauty of this is that you can then, even though it's subjective to the patient, you can compare a variety of different health professions. So this is just an example of something that came. The Browns, Gary and Melissa Brown out of Philadelphia, have done really the most work as it pertains to ophthalmology. And this is, as you'll see the reference from one of their many publications on this field. But so, for example, somebody with a low CD4 count in AIDS, they may be willing to give up 21% of their life expectancy if they could exchange that for perfect health for the rest of their life expectancy. And you can see many other examples down there of medical condition from a variety of different reference sources, so they're not comparing necessarily the same methodologies. As I say, I have a lot of suspicion about these utility values, but these are beginning to become the vernacular with which laws and policies are being constructed, so we do have to pay some attention. So again, the quality adjusted life year is really a product. It's the amount of quality or utility that a person has times their life expectancy. And you're going to see that terminology in several of the things that I'm going to go along with. So this is just showing that if we could get more health for a shorter period of time, that's approximately the same area or the same utility as having a partial improvement in health for a longer period of time. And to some degree, maybe this is some of the thoughts that have spawned the somewhat demagoguery death panels that were being described, 10 years or something ago, but I'm not advocating any death panels, don't worry. So some of the outcomes, as I've said here, are utility, and then multiplying utility times the years of life gets the quality adjusted life years that a given intervention or treatment might benefit. And then you can then assign a cost to what it costs to maintain that health and get a cost, dollars per quality. And then I'm not going to get into, but the marginal cost is also an important thing, the incremental cost-effective ratio. That's something like, we all know water, for example, you remember from your freshman economics, is very, very valuable, but it's pretty cheap, right? It's because on the margin, it doesn't cost much to provide the extra water, thankfully, that we need, at least in the United States, to function and live healthily. But it's obviously an invaluable resource. It's a necessary resource. Now, again, drawing from the Brown's population here, they've surveyed something like 50,000 people at this point and gotten these utility values for different levels of visual acuity. Now, there's some of it's the better seeing eye versus if it's the first eye versus the second eye, that can make obviously a big deal. But the point is that we have some numbers that we can begin to apply to some of the interventions. There's something called Markov modeling, which you probably understand, decision analysis. It's like you have a bunch of the X's there are different health states or different conditions, maybe a PVD or a retinal tear or a retinal detachment. And the lines indicate an intervention or a kind of treatment that might be offered for each of those with the outcomes of Y. And if you make an algebraic sum, albeit complicated, you can get some sort of decision analysis. And if you let a computer do that multiple times, depending upon which way it goes, that's called Monte Carlo gamble methods. And a computer can do that. And there's a lot of fairly sophisticated technologies for doing this. But rather than getting into those sophisticated methodologies, which are frankly a little beyond the practitioner, I like to think that you just use your head. If you can write it on the back of the envelope and make it, if it's so obvious that you can decide it on the writing on the back of the envelope, then it's really obvious and we should be paying attention to it. Another concept we should introduce, if you haven't heard of already, is this concept called the willingness to pay. In other words, how many dollars per a given quality is society willing to pay for a given thing? Now, in Medicare, we don't really make those decisions, right? You submit the bill and maybe they pay it, maybe they don't, but they don't ever give any analysis in this. But as a general rule, the willingness to pay actually turns out to be close. It's different from country to country and frequently is about the per capita GDP. There's there's a lot of other terminologies that describe this, but maybe 10 years ago, 20 years ago, this was quoted as being about a $50,000 per quality. Now the willingness to pay has gone up to $100,000, and some people just seemingly arbitrarily have said, well, we go up to $100,000 now. So listed on the right of this slide is just showing the dollars per quality for a number of different interventions. You see in there in the middle, reconstruction of an ACL is about $10,000 per quality. If you look down to the lower part there, though, peritoneal dialysis or hemodialysis is over $100,000, and this is like $2009. So this is when you might have thought $50,000 is useful. So how can we apply, or how do some of these numbers come here? Well, screening we learned also probably in the first year of medical school. We all must have taken a biostatistics type course, and we hear how important screening is. And screening is important, but only if it's targeted properly. And we can see from a lot of different slides that are up here, but starting on the left that screening for hypertension and diabetes and things of that nature are important, but only if you're using a cost-effective screening methodology, if you're targeting the right group of people. It can be very, very effective in that regard. So it doesn't cost anything to get a TB test practically. So we get a TB test on a lot of people, when we're doing our workups and such like that. What we've done is a couple different studies here. The upper right is showing how targeting screening of nevus. How do we screen from choroidal melanoma? And here again, we can see an upper level showing that those reds are the most cost effective, because that's when we're really targeting not only the age group that is has the highest incidence, but also the people with the more risk factors that are more appropriate. So targeting or following nevi is important, but the effort to do all those different tests that the AAO suggests is probably more efficiently applied towards the person in their 60s who has a risk factor or 3 from their nevus. Similarly, looking for hydroxychloroquine toxicity, the lower right is showing how we applied some of these numbers and found that, applying it, that the lower bars indicate a lower cost per screening per QALY. So it's very valuable to apply screening to people who are over 5 milligrams per kilogram per day, or if they've been on their hydroxychloroquine for more than 5 years. Again, I don't want to get us in the weeds. So we've been able to apply these kinds of principles to a number of different disease processes, and what I'd really like to do by way of being practical for you is try to just highlight a couple of these different studies that we've done. What about PVD? It's very typical. We see a patient come in with their flashes and floaters. Well, is that really, how often? What's the yield in that? Is it really valuable? As it turns out, it really is very valuable because you can find some very costly or avoid some very costly in terms of utility problems for a relatively low dollar intervention at that point in time. So again, we go through this decision analysis and apply some a Markov modeling type approach, and we can find that, can you believe it, that screening for a PVD is well under 1,000. It's only on the order of 100 to 200, depending upon the circumstance, depending upon the follow-up schedule. It's well under $1,000 per QALY to do that. So this is a highly effective and a highly valuable service that we can apply on a population-based healthcare basis. What about retinal detachment repairs? It doesn't look like it goes by. Oh, there we go. So here's our decision analysis for retinal detachment. You can make certain assumptions, as we did here, that maybe at the time we wrote this, 8 or 10 years ago, that sclerobuckling might be the first thing to do, and then if that fails, you do vitrectomy. And some of those things practices have changed, but I think the name remains the same. The bottom line is the same, including cataract surgeries if you come to the point of doing vitrectomies, which induce that. And depending upon the value or the success that you might have with pneumatic retinopexy, you find that certainly looking at the far right-hand column here, by far the best is to get the retinal tear before it gets to be a detachment. It's only $362 per QALY to do that. But the other expenses are very acceptable when you compare it against the maybe then $50 or now $100,000 per QALY. Our interventions for preventing and then therefore treating retinal detachments is highly, highly cost effective. So we should, as retina specialists, walk proudly that this is a valuable and useful thing we should do, and we should be able to advocate in the appropriate circles that this should be continued. Diabetic retinopathy, a very common condition I'm sure we all see, and there's been a huge amount of very valuable studies that have come out, mostly now at this point in time, targeting and evaluating pharmacologic-based, intravitreal and based. One of the things I do always like to try to point out when we start looking at these things, that the little sneer I give is that, now we're talking about letters difference. You may remember, for those of you who have some gray hair, we used to talk about ETDRS and DRS. We used to talk about lines difference of vision, which, 5 letters per line. So keep it in mind that, it might be a statistically different couple letter difference, may not really be a clinically significant difference, and I think we all get that. But this is the protocol T showing for various intravitreal anti-VEGFs, that there's an improvement over the course of this 1-year study. But so if we apply some numbers to that and we compare aflibercept and ranibizumab and Avastin, we can find that Avastin is a lot cheaper, right? It's about 80% or so less, 60, 70, 80% less to accomplish effectively the same thing. You're seeing again the graphs on the right showing that really everything is relatively cost effective compared to that $50,000 to $100,000 willingness to pay. But anti-VEGF treatment with bevacizumab is super cost effective. And in the way of targeting, we don't want to just shut down all the work that's been done and all the good things that the other branded agents have shown us. But one of the subset studies of Protocol T was to show that if you start with relatively good vision, then you can stay with relatively good vision. The results of all 3 agents are about the same, which is the graph on the right. But the graph on the left shows that there's maybe more of a benefit to the branded agents if you start with poorer vision. So maybe you should target the people 20/50 or better with Avastin and reserve your branded, more expensive agents for people with poorer vision. What about proliferative disease, diabetic retinopathy? That's been, maybe 5 years ago or so, and now I think has grown into penetrated practice. We're starting to less and less do PRP and more manage these patients with intravitreal agents, which seems to me also to be a little bit expensive and short-sighted, but we'll see some numbers of that. This is just a brief history of the treatment of proliferative retinopathy, going from how PRP was the mainstay, early vitrectomy was found, especially in younger diabetics, to be beneficial, and then this protocol S, which was evaluating the use of ranibizumab for proliferative disease, and Clarity evaluating the use of aflibercept, showing that there's inferiority studies. It's non-inferior to PRP. So we've done a series of studies, again, in the same fashion, comparing, using data from the Protocol S, the Clarity, and some other things, as well as the hypothetical studies that we've done here. This is the Protocol S, showing that after about 2 years, you see whether you use ranibizumab or PRP, you get about the same. I mean, the mean letter change is plus or minus a couple letters of vision. But the people who would be advocating for using anti-VEGF would say that, well, look, there's an area between that curve, so there's a cumulative quantity of benefit that's more than just the endpoint. And they may be right, but then again, the patient's got to come in every month, 2 months, whatever it is, for injections. They don't lose as much peripheral vision. If they have some commensurate DME, then there's benefits. So I'm not saying that there's an answer. I'm just pointing out that there's some considerations. So we applied the same kind of decision tree analysis, the Protocol S, and find that, here, the use of PRP is a good bit less in terms of the cost per quality than using, in this case, using Protocol S and ranibizumab. But if we look at that lower bar there, using bevacizumab is even more cost effective than using PRP, which was a bit of a surprise to me, but making certain assumptions. And same thing here, if we extend it to lifetime, because those studies were only for 2 years, and making reasonable assumptions, we can find that PRP and intravitreal bevacizumab are far less expensive than the branded intravitreal Avastin, intravitreal anti-VEGFs. Similarly, when we use aflibercept, we find a similar spread of numbers, that non-branded or PRP is much less expensive, and this graph shows this more summarized way without having to go through the numbers. Another study we did was to say, well, suppose we consider doing a vitrectomy at a much earlier stage. Is it just investing that cost of a vitrectomy early? Does that save us having to use lifetime injections or losing peripheral from PRP? And we find that actually the vitrectomy cost per quality is about the same in doing a vitrectomy versus doing a PRP, and both are at least half, and maybe a 2/3 lower cost than maintaining such a patient on anti-VEGF treatment. And if we do some sensitivity analysis, say, well, if we're going to maybe presume that after the first year or two we can do fewer injections, we'd have to do a whole lot fewer injections even to approach the value of PRP or PPV. And so the answer is really, even with those assumptions, a vitrectomy or PRP is cheaper in the long run. I'm going to just skip over this part. The conclusion for the proliferative disease studies that we've done here is to say that, well, certainly we know that PRP and even vitrectomy is far less expensive than using branded anti-VEGF agents, but maybe what we should do is really consider targeting some alternate treatments rather than, again, just throwing everything out. And I'm not here to fully diss, the makers. They've given us great results for a variety of disease processes at this point. So I'm just saying, how can we use that tool more effectively? We don't use the sledgehammer for everything. Tack hammers are good too. So we could consider targeting these subgroups. So maybe an early vitrectomy, a vitrectomy or a laser might be very effective for the young patient, especially if they don't have any coexisting macular edema. Whereas bevacizumab might be a good agent if we're feeling that we have to suggest for that patient intravitreal injections, and then accelerate or use as rescue therapy the other more expensive branded ones. And I'm just wanting to raise the issue, not go into any detail. We've also looked at the results of this Protocol W from the DRCR, which is looking at the prevention of macular edema and proliferative disease by doing early injections on people with moderately severe or severe non-proliferative disease. I mean, that opens up a whole nother population of patients with, $2,000 per dollar shot things. And, it's hard to show visual differences here. So this is an example like glaucoma, for example, and like some other fields where we really can't assign utility values on the basis of visual acuity. And we have to start saying, well, can we consider the utility of preventing macular edema, and then looking at that dollar value and saying, is that intuitively valuable enough to us to prevent that? And we've, again, done this and found certain things. But really the elephant in the room that I've been pointing out throughout this talk is that this long-term therapy is quite expensive. In fact, 3 of the top 6 drugs here in this article I pulled out of Wall Street Journal a couple years ago are eye-related injection medications. Now, to be fair, the Avastin, which is number 6 on that list, was that price was mostly at the time driven by, colon cancer and such. But the other little elephant in the room is it's not right to fool Mother Nature, right? I mean, all this treatment that we're doing, we're altering what the Creator has created us to be adjusting for. Although we're living in a sinful world, so we're wearing down, but just we hear some inkling that maybe there's problems with anti-VEGF treatment that's being done chronically, whether it's RPE atrophy, whether it's the potential for cardiovascular events, something we need to pay attention to. But beginning to conclude here, I just want to point out that most of the diabetic retinopathy interventions, especially the non-injection based ones, or other retinal interventions, and glaucoma for that matter too, we've done some work, are far below that bar of the willingness to pay in comparison to maintaining patients with long-term anti-VEGF injections, and in comparison to some of the other things like dialysis. I mean, hemodialysis is an extremely cost-ineffective way of treating. So if we can figure out a way I'll leave that to some other people. So again, these anti-VEGF injections are great blessings. They've restored and maintained sight for a lot of people. I don't know if they're helping the majority of people, but they're helping a lot of people. They're expensive. We should keep that in mind, and we should, but still not throw away our old tools, namely vitrectomy and PRP. And one of my favorite presidents, I'm interested in presidential trivia, is Calvin Coolidge, and this is one of his famous quotes, is that nothing's easier than spending public money. It doesn't appear to belong to anybody. The temptation is overwhelming to bestow it on somebody. And of course, if you're ever in a point of saying, well, we need to withhold this, you can't come out looking good about that, right? You look like you're a cold-hearted, money-changing person. But a corollary of that, and the reason I think that we continue down the road that we are, is that it's, as a politician, it's much easier to get votes or patients, if you're a treating doctor for that matter, by giving something or proposing something to a patient than it is by telling them that we want to withhold something. I find myself having a harder time sometimes convincing a patient how not to do something than to do something. And you get paid more to do something than not to do something. But I'm just going to leave you with entreat you to try to not get too caught up in that everyday type stuff I was saying, and say, does that patient really need this? Do they not need it? Can we do this in a more cost-effective way that will maybe leave some Medicare around for when some of you non-gray-haired people get to have gray hair? Thank you very much for your attention today. I didn't go over too much, so it looks like we have a couple of minutes if there's any questions.
How would the cost effectiveness for injections for neovascular AMD compare to diabetic macular edema? It seems just cursory that it would be less cost effective given the time of life left.
The question was, how does the cost effectiveness, the dollars per quality for treating AMD compare to this? And honestly, I've not really studied that in as much detail. I did it in a preliminary way with some other things, but I think what you're saying is correct, that if we target it right, it can be cost effective, but not as cost effective as diabetes. Why? Because we have generally a longer duration. So remember, it's utility times life expectancy. So diabetes is really the mother lode, the really good thing that we can put a lot of effort to, not only here, but overseas. I mean, there's a lot of diabetes in the Middle East and other parts, so it's important. All right. Oh, of course.
I had one other question. When you're looking at the cost analysis, does that include multiple visits and the people taking off work to bring family members to $30 a day for parking in academic centers and all that kind of stuff?
You're describing what's called indirect costs. I have done some studies looking at what does it cost to bring patients to a clinic. And you're right, there's enormous hidden costs. I mean, Where we practice mostly in Miami, there's people flying in from other different places and in the Caribbean and what have you. And you're right, the indirect costs are another sizable fraction of the actual costs. But of course, those indirect costs don't come off the government dime, so they come off your dime.
Bill, great presentation. Thank you very much. And having had the chance to publish in a few papers in these topics, I really want to encourage you to do a great publication in Survey of Ophthalmology and putting examples, real life examples of all these concepts. Most of us in the medical field don't understand these things, but it would be great that we can start introducing them in our talks out there, because politicians and decision makers, they understand these type of things, and particularly when prevalent diseases are very prevalent. By the way, we're trying to do with Eddie Alfonso and Zubair Ansari a population-based study in the zip code 33136, what Eddie wants to call it the healthiest zip code in the U.S. So I have to visit you
That's
sometime
hard to
next
imagine.
You never know. We'll get to do it, but I would be happy to talk about with you with that.
Thank you.